Hello everyone, my name is Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel, click our notification bell. Good afternoon, everyone. My name is Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. Welcome to another session where we will be talking about cancer with one of our guest speakers. I'm going to introduce you very well, but I want to first say welcome, Dr. Rufus. It's nice to see you. Thank you for honoring us, and thank you for coming on board and supporting us on our campaign to create cancer awareness, especially in Nigeria. Today we're going to be talking with Dr. Rufus. Any questions you have, start to put them in the chat box once you are ready, and we'll take it from there, and I will give him all the questions as we go ahead. I will like to introduce Dr. Rufus, but before I do that, I want to say hello everyone. How are you? The sun's shining now, at least in England. The weather is looking quite nice and sunny and bright, and that tends to give us a smile. Dr. Rufus, I'm sure you're used to all the sunshine where you are. Yeah. And for those in America, I'm not sure what their weather is like, but welcome on board this morning. So let me, without too much talking, let me introduce Dr. Rufus so he can start. And he's going to give us a brief presentation as we usually do. And then we can start to ask the questions. So Dr. Rufus, I call him Dr. Rufus. His name is Dr. Rufus Wale Ojewola. And he has obtained his medical degree from the Obafemi University. How do you call it? Obafemi Awolowo University. Put it properly. I think it used to be called Ife before.
University of Ife then.
Yeah, it used to be called, yes. He is a fellow of the Medical College of Surgeons and the National Postgraduate Medical College of Nigeria, a fellow of the West African College of Surgeons, as well as a fellow of the American College of Surgeons. Dr. Ojewola is currently a consultant urologist with Lagos University Teaching Hospital, Lagos, and is a senior lecturer in the Department of Surgery, University of Lagos, Nigeria. We'd like to welcome you with all this.
Thank you. Thank you.
You know, when I look at all these, we have one. We're always very satisfied. We have plenty. Thank you. Thank you, and welcome on board today. Today, we're going to be looking at the discussions still on cancer, and he'll be looking at it from the perspective of the urologist and how it can help us to create our awareness. So over to you, Doctor. It's your slot now.
All right. Thank you for having me, Dr. Denise Ejo, and good afternoon to everyone in this meeting. I've been introduced. I'm a urologist practicing in Lagos University Teaching Hospital in Nigeria, and it is my pleasure to be here this afternoon to talk about an important topic, prostate cancer. I will just give a brief introduction. There is no PowerPoint presentation, but I will just say some things about prostate cancer generally. Then I believe I'll be able to talk more about it when questions are coming in. I would like to start by saying that prostate cancer is the most common cancer in men beyond middle age. All men beyond the age of 50, if you pull them together, the most common cancer among these age group is prostate cancer. And because of that, it's a very, very important cancer that all men should know about. And of course, all lovers of men, I mean their wives and their relations, should also know about it so that they can advise men on what to do. Having said that, it is important to also know that in this environment, the way prostate cancer are diagnosed is quite different from the way or the stage at which it is diagnosed abroad. And this is very pathetic because Nigerian men tend to present late. And by the time we are detecting that they have prostate cancer, it's already at an advanced stage. And of course, with advanced stage, the prognosis is very poor. Death is more likely if it is discovered at that stage. So we definitely need to do something about it in Nigeria. One other thing I would like to say is that prostate cancer can be without symptoms. Most of our men in this part of the world, we want to wait until they begin to have one problem or the other, possibly with their urinary urination, before they present in the hospital. But it is very, very possible that prostate cancer can be diagnosed even without symptoms. And finally, on the introductory note, I will say that if prostate cancer is diagnosed at the early stage, usually stages 1 and 2, it is curable. We have effective treatment that can take care of them. And as a matter of fact, I have quite a number of patients who are diagnosed at this stage and have survived for more than 15, 20 years. So if it is detected at the early stage, then it is curable. But once it escapes this early stage and it gets to the advanced stage, it is not curable. All the doctors can do is just to do palliative treatment, pending the time that the cancer cells will, kill the patient. So having this at the back of our mind, we all, agree with me that we need to do a lot of mobilization of men, and we need to do a lot of awareness among men so that they can do the needful in terms of getting their cancer detected early, which I'm going to talk more about. I'll move to what constitute the risk factors in developing prostate cancer. Like most other cancers, the cause of prostate cancer is not known. There is no particular thing that is responsible for development of prostate cancer. But what we know is that there are risk factors that predisposes a man to developing prostate cancer. And I will talk briefly about some of these. There are what we call major factors, major risk factors. These are established factors that research has confirmed the relationship between them and development of prostate cancer. Examples of this is age. Prostate cancer is not very common in men below the age of 50. Even though we are beginning to have younger men, 42, 45, having it, but of course the prevalence or the frequency of prostate cancer in these age group less than 50 is quite low compared to above 50 years of age. So age plays an important factor when we are talking about risk for developing prostate cancer. And of course, the risk of developing prostate cancer increases exponentially from 50 to 60 to 70. That is, at one age, the risk increases. So age is a major risk factor. Aside from age, another major risk factor is positive family history of prostate cancer. Prostate cancer is one of the cancers that runs in family. So if a member of a family has developed prostate cancer, the risk of another member developing prostate cancer in that family is higher than the general population. And it's important to know that the higher the number of family members that are that have developed prostate cancer, the higher the risk. For example, if just one family member has had prostate cancer, the risk for another man in that family just doubles. But if 2 or 3 other members of that family has had it, the risk is almost times 10 compared to the general population. So it's very important. When we are talking about familial or hereditary tendencies in prostate cancer. Still along that line, there are some families that their great-grandfather, their grandfather, and their father has prostate cancer. It is very likely that the son or the males in this family are likely to develop prostate cancer because it has very strong genetic penetration in the family. So that is the second important major risk factor in developing prostate cancer. The third one is race. It has been discovered that the prevalence of clinical prostate cancer is higher in Black men compared to Caucasians and compared to Hispanics, compared to Orientals, people of Oriental origin. So in America, where we have a mixed population, the incidence of prostate cancer among Black men there is higher compared to other racial groups. It is also important that research has also established that Black men of West African descent are even more predisposed to developing prostate cancer than even other Black men. So, as Black men, we are more predisposed to developing prostate cancer, and we must not take the campaign and awareness among ourselves very lightly. We must do more so that more men are aware of that. What are the other risk factors? If I may add, any man with a functioning testis is at risk of developing prostate cancer. Prostate growth and development, and also development of cancer inside of it, is dependent on hormones. It has been found that men that are castrated for many reasons, for any reason, men that are castrated, particularly beyond puberty, they never developed prostate cancer. So, presence of a functioning testis in a man predisposes him to developing prostate cancer. So these are major factors. If I come again over it, we talked about the age, we talked about the family history, we talked about the race, and I also talked about presence of testis. So those are the 4 major risk factors in developing prostate cancer. There are other risk factors, but they are intermediate or minor. An example of this is diet. A diet that is rich in polyunsaturated fatty acid, a diet that is low in microelements like decreased vitamin D, vitamin E, and selenium are things that have also been implicated. And of course, these are things that have been found to be contributive in a way to development of prostate cancer. For example, Chinese men of the same genetic composition but living in different areas, they have different risks of developing prostate cancer. For example, Chinese men living in America has been found to have higher risk compared to Chinese men living in China. The only difference is just the westernization of their diet and food that contains all these junks, polyunsaturated fatty acids. So we cannot underplay the role of diet because it also contributes in a way, even though it's not as major as the other 4 factors that I mentioned earlier. So these are major factors. There are other things like vasectomy, like human papilloma virus and things like that, but they are not established risk factors. I would not want us to go into that. How does patient with prostate cancer manifest? As I said in my introduction, there may not be any symptom, and this is what we call asymptomatic group. Their cancer is only diagnosed during routine screening, and the routine screening for men is usually with the use of PSA, serum prostate-specific antigen, the use of transrectal ultrasound of the prostate, and of course a digital rectal examination conducted by a doctor or by a specialist. So these are the 3 tools that we use to screen men. So if any of them is abnormal, then there is need for further investigation. And the only confirmatory test that we do to diagnose prostate cancer is prostate biopsy, where we take specimens from the different sides of the prostate and analyze it in the laboratory, and the result comes out as either positive for cancer or negative for cancer. So these are the first categories of people. Asymptomatic group, only detected during routine screening. This is the best way and the best time to detect prostate cancer. Almost all patients that are diagnosed without symptoms will benefit from curative therapy, and they will be able to outlive the cancer. And that is why emphasis must be on men going to the hospital to be screened with these three tools: the PSA, the ultrasound of the prostate, and a digital rectal examination, so that if need be, there is any suspicion whatsoever, then prostate biopsy can be recommended and it can be detected at this stage. If detected at this stage, it is curable in almost all patients. So, but waiting for symptoms to manifest, then move us to the next categories of patients. And these are symptomatic patients. These are patients that come to the hospital with one symptom or the other. What are the symptoms? These symptoms may be local symptoms. These are symptoms that are referable to the prostate as a result of enlargement of the prostate causing embarrassment to the flow of urine. So they may be having frequent urination. They may be waking up too frequently at night. They may be having intermittency, that is, they are urine breaking in the middle when they are passing urine. Or they can even have, inability to empty all of their urine, and therefore having feeling of incomplete emptying. These are lower urinary tract symptoms. They may be unable to hold their urine and they have to rush to the toilet. Their urine may even leak before they get to the low. These are symptoms of prostate enlargement. If the symptoms is just around all these symptoms that I've mentioned, then it is a local disease. But by the time men do not present at this stage, cancer means, like a crab, it spreads. And by the time it spreads, then it begins to affect adjacent structures other than the prostate. And therefore, there may be more symptoms like blood in the urine, which may come from the infiltration of the bladder. There may be blood in the semen, which may mean infiltration or involvement of the seminal vesicle. There may be bleeding from the anus, which may mean that the anus, the rectum, has been involved. There may be constipation. There may be incontinence. So these are still local because the organs that produce all these symptoms are still adjacent to the prostate. But it is unfortunate that some men will still not come at this stage, and they will now come at a stage when it has even left these adjacent structures and it has gone to other organs. And other organs that prostate usually goes to are the bones, particularly the lower back bones, the bones of the hip, the bones of the thigh, the bones of the chest, the ribs, and the sternum, and can also go to the skull. So prostate cancer has affinity for bones. So once it escapes from the prostate, it goes through the blood and gets deposited in any of these bones. So by the time patient presents at this level, it is an advanced disease already. It is not curable. So these are different stages of presentation. If I may come over it again, asymptomatic stage, no symptoms, patient just go for screening and cancer is detected. It moves to local manifestation in forms of lower urinary tract symptoms. Then it goes to the locally advanced disease, that is involvement of adjacent organs. And from there, it goes to metastatic disease. Aside from bones, prostate cancer can also spread to the liver. It can spread to the bone. It can spread to the skin. In fact, anywhere blood gets to in the body, prostate cancer can get deposited there. So it is a disease that can have widespread, manifestation if nothing is done at the initial stage. Having said all of this, these are manifestation. Of course, when they present in the hospital, we need to investigate them. Essentially, what we need to do is to repeat the same test that we use for screening. That is the PSA, the the transrectal ultrasound of the prostate, and the doctor will need to do a digital rectal examination of the prostate. If anything is abnormal, anything seems to be abnormal with any of these, then there will be recommendation that a biopsy of the prostate should be done. Biopsy can be done digitally, that is without any guide, but the gold standard in diagnosing prostate cancer is to do a transrectal ultrasound guided prostate biopsy. There are new developments about prostate biopsy now, and we now have MRI guided biopsy, and we have combination of ultrasound and MRI biopsies. But the minimum that should be done is a transrectal ultrasound guided biopsy of the prostate. And this is sent for histopathological examination, and the result comes out as whether it is cancerous or not. Not only that, they will tell us whether it is cancerous or not, we also have opportunity of knowing the aggressiveness of the cancer in form of what we call Gleason score. Gleason score is used to grade cancer. Can I continue?
Yes.
All right. Okay. So Gleason score is used to grade the aggressiveness of the cancer. And this is very useful for us as doctors in putting patients in treatment group when this result comes back to us. So having diagnosed that the patient has cancer from biopsy, the next thing we need to do is to know the extent, which we call the staging. How do we do the staging? Usually we need to do some radiological investigation. MRI, magnetic resonance imaging of the prostate, gives a fine analysis of the prostate and give us full information whether the location of the cancer and the extent, whether it's confined within the prostate or it has gone to adjacent structures. So MRI, particularly multi-parametric MRI, is useful. Where this is not available, CT scan can be done. So it is with MRI that we can now properly stage the disease. And I will give a summary of the staging. If the cancer is limited to the prostate and MRI cannot even see it, then that is stage 1. When it is limited to the prostate and the MRI can see it, that is, it is radiologically evident, then that is stage 2. In stage 3, it has gone beyond the prostate and has affected adjacent structures like seminal vesicles, which are in the immediate relation of the prostate, but not beyond this structure. That is stage 3. But by the time it leaves this structure and is now getting to bones and other distant organs, that is stage 4. So stages 1, 2, 3, and 4. Of these, 4 stages, stages 1 and 2 are called early disease, while stages 3 and 4 are called late disease. Stages 1 and 2, early disease, it is curable. And I'm going to talk about some of the treatments that we offer patients in this category. When it is gone beyond the prostate and it is now stage 3 or stage 4, the aim is not curative, it is palliative, because at that stage, it is not scientifically possible to cure that cancer. Therefore, all we do is to manipulate the cancer so that patients can have a reasonable length of time to live without symptoms and before the cancer overcomes the patient. So these are the stages. I will talk briefly about treatment. Stages 1 and 2 are pulled together as early disease. And as I said, aim of treating them is to cure them. And that is why emphasis should be on whatever we need to do for men to be diagnosed at this stage. In stage 1 and 2, what we do include what we call active surveillance. It's not all patients that we actually go and operate now. There are some low-grade disease. The aggressiveness of disease is not much. For example, patients that have Gleason 6 disease, that is not very aggressive. Patients that have low-volume disease, maybe out of 12 calls that are taken, only 1 or 2 are positive for cancers. These are patients that can be monitored. So we monitor them. For patients who has life expectancy more than 10 years, we monitor them by doing digital rectal examination, PSA, and ultrasound, and possibly repeat of the biopsies if need be, to monitor them. So if this disease does not progress, you keep monitoring them. There are some patients that have been on monitoring for 6 years, 7 years. Their disease has not progressed. Their PSA has remained around the same area. The glycine score on repeat of biopsy has remained the same. So these can be managed. So, but what do we do? When we keep monitoring this patient, if at any time we see evidence of progression, remember these are people who have life expectancy more than 10 years, then we offer them curative treatment, which I'm still going to talk about. So essentially, that is the idea of active surveillance, and it is done for selected men with low volume disease, low grade disease, and who has life expectancy more than 10 years. The second categories of patients, of treatment in this category is watchful waiting. If we have elderly men diagnosed of cancer and it at this stage, maybe 80-year-old, 85-year-old, or people who have life expectancy less than 10 years, there is no need to subject them to very radical surgery. Remember, radical surgery has their own problem. Radiotherapy has their own side effects. So if we detect these people at this stage, what we do is a kind of watchful waiting, where you may not really do anything if they are not having any symptoms, but when they develop symptoms, then you give them hormone treatment, which I'm still going to talk about. Not radical treatment. You're not going to remove their prostate. You're not subjecting them to radiotherapy. You just do some hormone manipulation. Remember, I said earlier that having testes in men predisposes them to developing prostate cancer. So the hormones that come from the testes, we can manipulate them. We can find a way of depriving the cancer cells in the prostate these hormones, and therefore it will curtail the cancer cells, will not allow them to grow, and will not allow them to spread. What do we do? Well, we'll talk about that later, but that is patients in wishful waiting. 85-year-old that have other comorbidities, maybe chronic obstructive airway diseases, hypertension, diabetes, and things like these are other things that can even kill the patient before the cancer. So once it is early disease and it is elderly with life expectancy less than 10 years, we don't need to be aggressive. But for younger men who are lucky to come for routine screening or who have just few symptoms and they are diagnosed at the early stage, the options for them include radical surgery, radical prostatectomy. Radical prostatectomy entails removal of the entire prostate and one of the adjacent structures, the seminal vesicles on both sides, and now joining the urethra with the bladder so that urine can flow out. These have been found to be curative for this stage of disease. And for younger men, it is important, that as many of them that have particularly high-grade disease or high-volume disease, this is what is best for them. That ensures that they are cured of this disease. What are the other options? The other option for people that will not want surgery include radiotherapy. Radiotherapy uses radiation to destroy the cancer cells, and this can be in form of what we call external beam radiotherapy. These are forms of radiotherapy, or what we call brachytherapy. Brachytherapy means planting some seeds that contain radioactive elements or agents in the prostate, and they begin to release radiation slowly. We have high dose brachytherapy, we have low dose brachytherapy, depending on the dosage and depending on the duration of action. So these radioactive include polonium, iodine, and many others. So it's another major thing. But it's important to note that people who do well on radiotherapy are mainly people with low-grade disease or intermediate-grade disease. People with very high-risk disease, they do better with surgery. People with high-volume disease, they do better with surgery. But in any case, radiotherapy is another major means of treating patients with curative intent. So these are for stages 1 and stage 2 diseases. I'll come over it again. Active surveillance. If you don't want to intervene for patients that have low dose, great disease, watchful waiting in very elderly who have other comorbidities, whose life expectancy is less than 10 years. And of course, we have radical prostatectomy, which is usually better for younger people with high-grade disease and high-volume disease. And of course, we talked about radiotherapy, which can be in form of external beam radiotherapy or in form of implantation of radioactive substances in the prostate called brachytherapy. So this is the summary of treatment for these categories. I'll move to now to
okay, can we take some questions, please? Because
okay, go ahead, please.
If there's anybody that has a question, please put up your hand. I think you've shared quite a lot, and I noticed that quite a lot of men are on the platform. So
all right, I'll be glad to take questions.
Rather they can ask. If they want to ask a question, they should just put up their hands. Please, if there's any man. I have a question for you though.
Okay. Maybe we start.
So while I ask the question first so that other people can feel comfortable enough to ask them.
That's fine.
Just a quick one. Looking at the, when you say if you have all these things, you get to a certain stage that it's not curable.
Yes.
But when something is not curable, does the first thing that occurs to any human being, especially when you live with cancer, is the first thing you think is you're going to die. Yeah, and everybody's going to die.
Yes.
But once you hear the word cancer and you hear not curable, the next thing you think is that means I'm going to die anytime now. And sometimes it's not necessary. It doesn't necessarily mean that. Am I correct in saying that?
Yeah.
Okay. Can you please feedback on that, because that I know will be an anxiety currently.
Yeah. All right. Thank you very much for that question. We are scientists.
Yes.
And we talk in scientific language. We are talking from the pool of evidences from treatment of prostate cancer over many years. The best that we want generally and that we can vouch for is when a patient presents in stage 1 and stage 2. If a patient presents in this stage and you do operation for them to remove their prostate, almost all of them, you can be sure that they will live to their full potentials. It doesn't mean that they cannot die of other things like road traffic accidents, diabetes, hypertension, and things like that. But from urological point of view, you can beat your chest and tell the patient that I do not think that this cancer will come back. One of the things that happen in cancer is people are treated with cancer, everybody is happy, the tumor is out of the body, and you think all is over. Only for cancer to reoccur. That is what we call reoccurrence of cancer. Sometimes 2 years later, sometimes 3 years, sometimes 4 years. So the probability that reoccurrence of cancer will occur is higher when it is in advanced stage. Even though the treatment that is given, all the treatments I've mentioned, when you institute it for a patient, they will all help the patient. There is no doubt about that. Even patients who are dying, by the time you deprive the prostate cancer of androgen, almost all of them will get well temporarily. It may now be for 3 months, it could be for 2 years, it could be for 5 years, it could be for 10 years. So in terms of possibility of reoccurring or the cancer coming back to give problem, it is higher in that categories of patients who present at a later stage. And that is exactly what I mean. We have seen patients with stage 1 and stage 2 treated and medically certified fit. And 1 year after, died of other problems not related to the cancer. And we've seen patients in stage 3 that are still hanging on for 15, 20, 25 years. The truth of the matter is that we can only predict, we cannot say for certainty what is going to happen. From experience, stage 4 cancer is not supposed to live, scientifically speaking now, for more than 5 years. But I've seen people that we diagnosed as stage 4 and we treated and they lived for more than 5 years, for more than 10 years. Yes, we have quite a number of them that also died within that window that we are talking about. So when I say it's not curative, it's a scientific language. If you go to see a specialist like a doctor, if it is at stage 3 and 4, no doctor will tell you that you've been cured. They will still need to monitor you. Yes, even after stage 1 and stage 2, we still monitor them. But of course, patients in stage 3 and 4, after treatment, whatever treatment you give, they need to be monitored for the rest of their life. For stage 1 and 2, after 5 years, after 10 years, you may choose not to monitor them for prostate cancer again. But for patients in the other categories, stage 3 and 4, they will have to be monitored because risk that the cancer will come back in form of reoccurrence is much higher in them. And when it occurs, there are also effective treatment to treat them. But that is exactly what I mean. It doesn't mean that they should go home and die, not at all. There are treatment and the treatment also work. But we as doctors will have loved that we get them at stage 1 and 2. We can beat our chest after all the treatment for them at that stage that yes, all is well. So I hope I've been able to answer your question.
Yeah, go on. I'm looking now. There are no hands up. Okay, go on. Go on. Yeah, we'll keep going. I have one more question, but go on.
Okay, all right. So if there's no other question,
Hello.
so
Hi.
If you have a
Hi.
question, just put up your hand and then I would see. I didn't see your hand up. Sorry.
Hands up.
Okay, go on, William. I heard your voice. Go on. I can see your name there. Okay. Sorry,
Okay.
Doc. Can we just take William's question quickly? Then we'll go on.
Right.
No problem. That's okay.
Hi, Doc. So my question
Hi,
is a bit of a loaded one.
Okay.
So we understand that one can actually have cancer. So and one can fall into all the different groups, which basically says you have cancer. The question is, right, what can you do, right, to fight cancer? So, for instance, we talking about diets and talking about exercises and talking about diets, exercises, etc. There's one common thing which has been bugging me anyway, and this is down to milk. So in the UK, we've got we've got green milk, blue milk, all sorts of milk. Now the question is, right, does that actually have an impact on your diet with the fight of cancer? So literally, this question is all around diet. So diet and cancer. What do we need to do, and what sort of exercises can we do to kind of stave off growth of cancer?
Doc, can we take this at the end of your presentation?
Yeah, that's okay? Right. Yeah.
Yeah. Okay. So that we just finish this presentation and then add. We'll bank it, and William will bank it, so we'll come back on it. Yeah,
that's great. Yeah.
All right. Thank you, William. All right. So let me continue with the presentation. I think I stopped at looking at treatment.
End of stage 2.
End of stage 2. Thank you very much. Thank you very much. So I will now move to what we do for patients that have stage 3 and stage 4 diseases. As I told you, at this stage, because it has spread beyond the prostate, we don't usually recommend surgical intervention, because if it has spread beyond the prostate, are you going to remove the bladder again? Are you going to remove the rectum? Of course, that is not compatible with life. So what we do is to find a way of palliating the disease, find a way of making sure that the cancer cells are starved, of making sure the cancer cells do not, grow and spread to other structures where they normally go to wreak havoc. And what do we do? As I said earlier, the growth of prostate is dependent on male hormones. And the growth of cancer inside of it too is also dependent on male hormones. So if we can do anything to make sure that male hormones do not get to the prostate, then we will impede the rate of growth and the spread of prostate cancer. And that is the general, mechanism by which
we treat patients whose cancer cannot be removed because it has advanced at the stage of detection. So how do we achieve this? One of the ways to achieve that is to remove the testes. About 90 to 95% of male hormones in the body are produced from the testes in men. So if you cannot go to remove the prostate and possibly where they have spread to, maybe the bones or thereabout, one thing you can do is to remove the source of androgen. Remove the testes, and the androgens are taken away from the prostate, and the cancer cells are also deprived of their so-called food, and therefore they do not metastasize. So removal of the testes is one way by which we deal with, patients in this category. However, not all men will want their testes to be removed. In fact, most men will not like that. So there are alternatives, and the alternatives comes in form of injections and tablets. We have different categories of drugs. There is what we call luteinizing hormone releasing hormone analog. These are drugs that act on the pituitary so that they cut off the supply of testosterone and other androgens in the testes. Examples are leuprolide, goserelin, Soladex injection, and a lot of others. They are in the market. And we have others too that we call antagonists, which actually also act at a higher level, like the level of hypothalamus. You know, hormones have axes. They have from one organ to the other. We have the hypothalamus in the brain, controlling the pituitary also in the brain, and the pituitary is the one controlling the testes and controlling the adrenal gland. I'm sorry that I'm speaking medical languages now. This is the pathway. So at any of these levels, we can interfere with the production of androgen. So I've mentioned luteinizing hormone releasing hormone analog. There are also antagonists. So these are drugs given in form of injections that usually prevent the testis from producing androgens. And if testis is not producing androgen, it will not be available in the blood to get to the prostate, and therefore, usually, it causes remission. People who are having bone pains, the pain will stop. People who are having low back pain, the pain will stop. We have even seen patients who have developed paralysis as a result of prostate cancer spreading to the spinal cord. If they present early and the androgen source is taken off almost immediately, we've had a reversal of that. And I have many patients that I've personally treated who are already having impending paraparesis or paraplegia or weakness of the limb or paralysis. And when this is done, either you take off their testes or you give some of these injections that I mentioned, then they are back to life because the cancer cell have been deprived of their food. So this actually works. But it is important to note that even though they work, but because the cancer cells are still there, after many years, it could be 2 years, it could be 5 years, depending on the aggressiveness of the tumor, depending on where it has gotten to, they may get strength again. And there are other treatments which I'm still going to talk about. So I've talked about this, but we also need to know that aside from testes in men, there are other male hormones coming from the adrenal glands. So we need to take care of this too, because even if the male hormone from the testes are not getting to the prostate, if prostate can get supply from the adrenals, the cancer will continue to grow and will continue to wreak havoc in other parts of the body. So there are what we call drugs that we call anti-androgens. Even if you have removed the testes, even if you have stopped the production by giving those injections I mentioned, you still need to administer some drugs that will mop up or counteract the effect of androgens that are coming from other sources. And these days, what we do is combination. So we may give somebody injections and at the same time give these anti-androgens as tablet so that they can have maximum effect in what we call maximum androgen blockage or total androgen blockage. So this is the summary of what we do when patients come late that we cannot operate on them, stages 3 and stage 4. I forgot to mention for that stage 1 that for radical, your prostatectomy, it can be by open surgery. That is what is available to us in Nigeria and in most part of Africa. But these days, it is usually undertaken by the use of robotics in the advanced world, in the UK, in America, and even in Asia. But we don't have a robot in this part of the world. So what is still available for patients who are qualified is to have open radical prostatectomy. So having done all of this, patients may also present with complication of prostate cancer. We need to treat them too. For example, patient may be passing blood in the urine, and this could be severe enough to cause anemia, to cause shortage of blood. And there may be need to give this patient blood tonic. There may be need to even transfuse with blood. Secondly, patient, because of the enlargement of the prostate, the cancer therein may cause blockage, and patient may go into retention, unable to pass urine. In these categories of patients, we may have to pass a catheter, and of course, if the catheter, passage of catheter does not relieve the obstruction after some time, then we may consider this patient for what we call channel TURP. Channel means we just go, not that we are going to remove the entire prostate, but we just remove the inner core of tissue that is blocking urine from coming out so that patients can pass urine themselves. If patients present so late that the obstruction in their urinary pathway has caused renal impairment, renal failure, we have a number of patients that come and the only thing we just see is that they have renal shutdown. So patients may have to depend on dialysis, and patients, some of them, we require that you catheterize them for a long time so that kidney can recover from the chronic obstruction. For other patients who have bone metastasis, it has gone to the bones and they are having severe back pain or severe bone pain in any part of the bone, we can recommend that they have radiotherapy. Focal radiotherapy to this point may relieve them of the pain, and that is available in Nigeria, particularly to us in Lagos University Teaching Hospital where I work, and I know is available in some other centers in Nigeria. If there are other problems related to the cancer that the patient presents with, then that also has to be done. So this is a form of treatment. In terms of prevention, I think it is important for me to talk about that too. The question is, can we really prevent prostate cancer? The answer is no. We cannot entirely prevent prostate cancer. And the simple reason for that is because the major risk factors are things that you cannot modify. For example, I talked about age. Even if you change your age on your certificate, your biological age is ticking. You can't change your age, and aging predisposes one to developing prostate cancer. Number two, I talked about race. If you are a black man, you are more predisposed genetically. Even if you bleach and you become as white, or you live abroad, it does not remove that genetic makeup that you are a black man. So you can see we cannot modify that too. Number three, we talk about family history. Even if you like, you can change your name. You are still genetically a member of that family that have positive issue of prostate cancer. You can change it. You can change your name. You can change your location. The blood in that family still runs in your system. So you are predisposed. And finally, I talked about presence of the testes. I do not know, and I have not come across any man that will want us to remove his testes because he does not want to have prostate cancer. So if you look at these major factors that I've mentioned, you cannot modify them. And they are the most important when it comes to prostate cancer. So you cannot entirely prevent prostate cancer. However, as I mentioned earlier, diet has a little role, not a major role. And maybe this will also answer William's question to some extent. Whatever type of milk, be it blue milk, white milk, or whatever. Any milk that is high in polyunsaturated fatty acid, that is low, or any diet whatsoever, not only milk, that is low in vitamin A, vitamin D, and selenium. These are micro elements. They have been found to, in a way, predispose to developing prostate cancer. And that is why I've seen a lot of mixtures and a lot of capsules coming from America, from UK now. They call it prostate diet, prostate this, prostate diet. What those formula tend to do is to make sure that you have enough selenium, enough vitamin E, enough vitamin D, and low fats in those things. These are things that are found to be healthy to the prostate. So, whatever milk you are picking up, whether blue milk, white milk, or whatever, it will be nice to look at the content. And if the content says it has a high amount of fat, and you cannot see correspondingly higher level of those things that are found to be protective, selenium, vitamin A, vitamin D, I will not say that you should not take it, but you shouldn't take too much of that. After all, too much of everything is not good. So that will be my suggestion. Diet has a role to play. So that little role, it is important that we play it. Eat healthy. Not too much of fat, not too much of junks. Eat what is generally healthy. And by doing that, you are reducing, no matter how little it is, the risk of developing prostate cancer as a man. But as I said, the major risk factors are things that we cannot do much all about. Now that I have said that we cannot prevent prostate cancer entirely, what is our role? Our role is to make sure, yes, we cannot prevent it, but if prostate cancer develops at all, every man should do what is supposed to do so that the cancer will be detected early. And that is when the role of screening that we talked about earlier becomes very, very important. What do we suggest or what do we recommend? For any man who is above the age of 50, there should be a routine and annual check that we call prostate check. And this includes, as I mentioned earlier, running a prostate-specific antigen test, doing ultrasound of the prostate, and also allowing a urologist or a doctor to put finger in the rectum to feel for the prostate and do a digital rectal examination. There are things that doctors look for that may show abnormality when they examine. It could be hardness, it could be roughness, it could be irregularity, and it could be one side of the prostate bigger than the other. That is very important and should be done on a yearly basis. Number 2, prostate-specific antigen. Normal prostate level is between 0 and 4. Between 4 and 10 is said to be gray or intermediate zone. And any prostate-specific antigen level that is more than 10 is abnormal. So when we do PSA and it's more than 4, it's an indication that further tests should be done. Prostate biopsy should be done. Between 4 and 10, there are a number of other tests that can be done, like looking at the free PSA, total PSA, looking at PSA density. These are things that doctor puts in consideration before they recommend a test. But in most places, when PSA is more than 4 nanogram per mil, it is an indication that prostate biopsy should be carried out so that prostate cancer can be confirmed or can be ruled out. And the third screening test is ultrasound of the prostate, which is best done by transrectal ultrasound. There is a probe that will be inserted in the rectum, and that will give an excellent imaging of the prostate. And we look at whether there are nodules, we look at whether the capsule is intact or not, we look at many other things like vascularity, the toughness of the tissue in terms of elastography, stiffness of the tissue, and these are things that can help one to know whether it is a normal prostate or not a normal prostate. So men should go for this screening when they are 50 years, and this screening should be done on yearly basis. However, for men who have positive family history of prostate cancer, their own screening should begin as early as 40 years of age. So if any member of a family has been diagnosed or have died of prostate cancer before, such other members of that family that are men should start their screening from 40 years of age. So what we preach, since we cannot prevent prostate cancer entirely, the drive and the message should be towards men coming out for screening. There is no need for men to wait until they begin to have symptoms. No, you don't have to have symptoms with urine problems or whatsoever. Every year, make it a point of duty. In some places, this is tied to people's birthday. The month of their birth is a month that they go for this screening, so that if anything is abnormal, they do biopsy and it is usually detected early. In places like UK and America, they don't do ultrasound like we do now, but that is what is available and still very useful to her. But in UK and in America, what they do is MRI of the prostate, multi-parametric MRI, and that will give good information about the prostate, and patient can be investigated further. So the message is that men should not wait until they begin to have symptoms, because of the inherent risk in men as a result of their age, as a result of their race, as a result of their family, and as a result of them carrying 2 testicles still with them, producing androgen hormones. Then they should make it a point of duty to come for screening on yearly basis from 50 years of age for men without family history, from 40 years of age for men with positive family history. So I think I will stop here and take more questions. Thank you very much.
Thank you, Dr. Rufus. I'm trying to check. William, thank you very much. I hope that answered your question. And if it didn't, just let me know and let us take it. I've got one more question before I shut down, but I just want to make sure that if there's anybody that has a question, either put up your hand or try and, I think Osi has a question. Okay, let me let everybody else put a question and then we'll take it from there. And if I have space so that we don't because we're already at 1 o'clock and I don't like to overrun. So Osi, I'm going to ask you to unmute yourself now.
Right, good afternoon. Can you hear me clearly?
Yes, we can hear you very well.
Oh, excellent, excellent. I'm speaking as somebody whose father has prostate cancer, so I've always been aware of trying to do the right things. Thank you very much for your presentation, Doctor. There were 2 things I was not aware of, which was the multiparametric MRI and the transrectal ultrasound. The ultrasound, I don't think they'd offer it here as a, if you like, an off-the-shelf diagnostic tool. Yeah, one might have to go private for that, as well as the MRI. But what they do offer is PSA tests and the DRE. First time I went for DRE when I was in my early 40s, I was actually refused. I said, "Oh, I was out of the scope and all that. I should come later." which I intend to do once this COVID thing's over. Thank goodness I haven't had an abnormal PSA. I've tried all the normal things, exercise, I try to walk 5 miles a day, diet, I've cut out wheat, dairy, and sugar for about 9 years. The one thing I wanted to ask, this question, it comes in 3 parts. Same question, but in 3 parts.
Okay.
You see it flying around different fora. It's about sex. Now, does sex reduce the likelihood, or does a lack of sex increase the likelihood? And then, what would be a medical definition in this context, regular sex that could be beneficial to prostate cancer if it can be proved? Because I'd like a medical definition, because if you go by my own definition, I might kill somebody's daughter. That's to defeat the purpose. So over to you, doctor.
Keep saying that, Osi.
Thank you, Osi, for your questions. Let me start with the issue of sex. Sexual intercourse, or either excessive or inadequate, is one of the erroneous impressions that is flying all over the place. As a matter of fact, we found prostate cancer in men who were never married. We found it in men who have several wives. We found it in all categories of men. Till date, there is no scientific evidence that linked sexual activities, whether in adequate quantity or excessive quantity, to development of prostate cancer. They are still erroneous impressions. Science has not proven that. And I will take it from that because there are other erroneous impressions. One of them is multiple sexual partners. The same thing, that has no role in development of prostate cancer, whether you are married to just one wife or you have a lot of concubines. Yes, it's good to live a decent life, but whether it is one or many, it has not been scientifically proven that it has a relationship with. The other things that people talk about are people who develop sexually transmitted diseases in the course of their life. Maybe when they were much younger, that maybe they were more predisposed to developing prostate cancer. Science has not proven that true. They are still erroneous impressions. As I said earlier, things that have been proven in almost all studies across continents and countries are the ones that I've mentioned. That is the age of the patient, the race of the patient, family history, and presence of testes. All the other ones are not proven. So I will answer that I have no recommendation as to, what is perceived to be adequate or not adequate before somebody kills another person's daughters. Okay. Now, still about
check, is there anybody else having a question so that when doctor finishes, I can just tidy up now? Does anybody, if you have one more question, I'm opening to take it, or I'll give my own question, and then we have to shut down. All right, then go and finish, doc, so that I can put up your hand if you have, or you let me know, or mute yourself so I can see that you want to say something. Go on, doc.
All right. Okay. I think the other aspect is what OC mentioned about MRI and ultrasound. These tools they are better called screening tools. They are not diagnostic. None of all these tests that we have mentioned, be it PSA, ultrasound, MRI, by itself is diagnostic of prostate cancer. No, they can only give a suspicious result, and therefore we prompt a doctor to recommend the confirmatory test. The only confirmatory test for prostate cancer is histology, and histology will only be done after biopsy of the prostate. So MRI, ultrasound, PSA, they are only suggestive that something may be wrong, and that's may mean that there will be need to do a more affirmative or more confirmative test in form of biopsy. So yes, they are just used as screening tools, and we recommend that, as I have detailed earlier, for all men who are at increased risk by the virtue of their age, family, and by the virtue of their race. Thank you. I think I should stop here.
Thank you very much. I'm going to actually start pulling us together now. I thank you once. A very, very big thank you to you, Dr. Rufus. I actually learned quite a lot. This is the first time I've been very, very quiet on a platform like this, honestly. And I think Commonwealth Cancer Foundation has some work to do here. Gosh, I've got one question. All right, Reverend Yinka, we'll give you the platform, but hold on a minute. I want to first pull off some of the key things that we've learned. The key thing that I think is key for all of us to share, and for the team online, can you please put out the flyers on this? These 4 factors about the age, family, race, and hormone. Can we make sure that becomes available on all our social platforms? Because I think the more we know, the more people are fully aware. This question that Osi asked about is sex and its implications. Maybe we need to make an awareness that that's not the issue and address other issues. So I'm trying to pick up the key things that have come up that we all need to be fully aware of from the discussions that have been held today. Reverend Yinka has a question, and once we do that, we're going to close on that question. So Reverend Yinka, or have you put your hand down? Okay.
No, I haven't. Thank you. Can you hear me, doctor?
Yes, I can hear you. Good afternoon.
Thank you very much. I've learned so much, even though I'm in the healthcare sector. I've heard a lot today, and I really love the content. Thank you very, very much.
Thank you.
I just want to find out. I have somebody that's been having issues with no, I don't know if it's prostate, that's been having issue with passing urine for the last like over 2 months. And first of all, it started having blood in the urine, and they thought it was like a UTI infection, and he couldn't pass urine for a while. They had to put a catheter, and it was done. But last week, because the thing was just getting worse, the person was sent to do some tests and had ultrasound PSA. And when I saw the result of the PSA, in fact, like you said now that it just gives indication, the PSA came as 33 ng per mil. And I kept wondering, oh my goodness, that is very high. It's got a catheter in situ, it's not feeling too great with passing urine. And I was just saying to myself, the next thing would be, this person needs to, you still have to go to hospital, lives in Nigeria, biopsy. But what will be your advice, please?
All right.
At this stage.
Yeah, thank you very much. The summary of what you have told me now, I don't know the age of the patient, but he has.
Sorry.
You can't hear him anymore.
Sorry. Put it back. Sorry. Put it back.
All right. I think I'm unmuted now.
Yes, you are.
All right. How old is this patient that you just painted?
The patient is 65-year-old male. Yeah, definitely.
All right. Okay, 65-year-old. All right. If I got you right, it's God's problem with passing urine and eventually led to urinary retention. And it has to has a catheter put on. And also is also passing blood in the urine.
Yes.
And more frightening to you is that the PSA came out to be 33 nanogram per mil.
Yes.
All right. Okay. Now, I will say in this patient, there's no cause for alarm for now. And the simple reason is because this man may still have non-cancerous enlargement of the prostate.
Okay.
Even though the PSA is quite high, 33 nanogram per mil. As I said earlier, normal is between 0 and 4. And of course, anything more than 10 is highly suspicious of cancer. But this patient has been passing blood in the urine.
Yes.
Any patient who is passing blood in the urine and the blood is coming from the prostate may have high PSA because the blood is leaking from the prostate into the urine and also into the blood system. And therefore, they have high PSA at that particular time. So I will say that we cannot treat this patient based on this 33 ng now. If you go to the hospital, let them, treat the hematuria, the blood in the urine. They know what to do, usually conservative treatment. When it clears, the first thing we need to do is to repeat this PSA when there is no blood coming from anywhere.
Okay.
In most cases, this PSA will come down. You may do
Okay.
another one when the blood is over and it is now less than 10. Do you understand me?
Yes.
But we don't deal with PSA alone in isolation. He must do a transrectal ultrasound. That's why it's important for him to go to the hospital. Not only to the hospital, he should see a specialist, he should see a urologist.
Okay.
And when we do the ultrasound or the MRI, looking at the prostate on imaging will tell us, is there anything abnormal there, or is just ordinary enlargement that is causing the problem he's having? And more importantly, the doctor will do physical examination by putting finger and examining the prostate. Is it hard? Are there nodules? And are there other things to suggest cancer? If the doctor does that and there's nothing to suggest cancer, we do ultrasound of the prostate, nothing to suggest cancer, or MRI of the prostate, nothing to suggest cancer. I believe if this PSA is repeated when patient is not having blood in the urine, it might be lower. If, however, it has not come to the level that is within normal, this patient, for the avoidance of doubt, should go and have a prostate biopsy. And that is what we confirm that, oh, it is non-cancerous enlargement or it is cancerous enlargement. So that is the starting point of his treatment. If, for example, the histology comes back and say, oh, it is not cancerous, we thank God for that. Then patient will benefit from all the treatments of prostate, benign prostatic enlargement that is not cancerous. It could be in form of removing the prostate if it's in Nigeria, that is still done in many centers, or we can do TURP, transurethral resection of the prostate, which is an endoscopic treatment. And in few places, even in Nigeria, we now do laser prostatectomy. At least it's available in some centers in Abuja. So if it is not cancerous, that would be the pathway. If not, because he has even gotten to the level that they have to put in a catheter now. Patients with ordinary enlargement, many of them do well on some drugs that we give them, tamsulosin, afusocin, duodat, and a lot of others. But for this patient that you just painted the picture, he has gone to the level that he cannot pass urine at all and now dependent on catheter. It may require surgical intervention at some point. If we do biopsy and it now turns out to be cancerous, the treatment in this man will depend on the stage. That means we need to do an MRI for staging and may need to do bone scan, which I did not remember to mention. Bone scan, because I told you that prostate cancer loves bones and spread fast to bone. Bone scan is one of the things that we normally do. Before now, bone scan is not readily available in Nigeria, but we are beginning to have one or two centers, private and government hospitals now, UCH Ibadan has bone, and we now have a new hospital in Lagos that has bone scan. So if this is done, if this particular patient at the end of the day, it is cancerous, but it is limited to the prostate, with 65 years of age, and patient unable to pass urine now on catheter, this will be an ideal patient to have radical prostatectomy, where all the prostate will be relieved. This will help him in two ways. First of all, it will eradicate the cancer, and secondly, he will be able to pass urine without catheter. So I think this would be my advice for this patient.
Thank you very much. Thanks a lot.
You're welcome. Thank you.
Thank you. I want to thank everyone. You see, 15 minutes over. I'm always trying. I always try. I really am sorry. And I'm going to stop. I don't have questions again. I want to say a very, very big thank you to everyone who has logged on today. I hope you found it useful. We will be sharing a lot of information. So please, can you follow us on our various platforms that have information on our Common Cancer Foundation? We have a YouTube channel, so at some point this will be posted on our Facebook page. You should be able to find information on tips that we've picked up today. So every tip that you have received today, you will find it on either our Facebook, Instagram, Instagram. They always laugh at me on this one. Instagram, our YouTube channel, Facebook, and you can find us anyway. Just check, you will find us. And we have a website, Commode Cancer Foundation, one word, .org. Just go on it and pick up anything, any information, send us a message, we will respond, and we still try. So if there is anybody that you think needs help, Dr. Rufus comes on board as one of our helps, because after this, he starts to be my guide. When anybody come up on anything to do with urology, I will ask him question that, sir, please help me. Somebody is like this, what do I do? And a lot of people that actually have come on this platform have benefited. We are a charity, we're an NGO, we don't raise any funds. We're not raising any, we're not calling for fundraising at this point. We're using this opportunity to create a serious awareness in Nigeria on cancer. It doesn't matter what cancer, we're going to continue to shout until it is heard and things are done. I want to say very, very big thank you to everybody that has come on. To our guest speaker, Dr. Rufus. Oh, I always get this wrong. Ojewala, yes. Ojewala. It's easier for me to call him Dr. Rufus, but let me
That's okay. That's okay by me.
Dr. Rufus, me and you are not the same doctor. Me, I'm doctor of book. You are doctor of medical. So that we don't get it wrong.
So you are a fake doctor. You are a fake doctor.
No, I'm not fake. I'm original on the other side. On the other side, because me
on the other side. Yes, non-medical doctor.
No, not medical type. No. Let's enter different lane.
Yeah.
So I want to say thank you all for logging on. Please share the information. Go and visit us on our social media platforms. Have a lovely, lovely Saturday, and thank you for giving us your time. Have a good afternoon.
Thank you.
Done. Now
bye-bye.
I'm not recording anymore.
Okay, bye-bye.
Bye.
Bye.
Bye. Bye.